I'm a doctor of clinical psychology, and I have the very good fortune of working with some tremendously really bright and impassioned clinicians that you've pretty much met today. Weren't they great? So I'm essentially comic relief. So you know, I figured being the last speaker, they allotted me 20 minutes, so I figure I'll take 10 and everybody will be good. So I wanted to talk about psychosocial resources, and actually, Sung actually talked about a lot of them, and I call this outside in and inside out because you guys are the most powerful resource you have, period, no questions. Everybody that woke up one morning and said, I'd like to have a dose of melanoma, please raise your hand. Right? Cancer is scary. Cancer is hard. So when people get cancer, there's a whole bunch of needs that go boom, right in the face. And approximately 30% of all patients diagnosed with melanoma report levels of psychosocial distress high enough so that people should be getting help, right? And a lot of times in America, we're John Wayne sort of folks, and we want to tough it out, right? So folks don't get the services they need for all these wonderful things. Depression, distress, fatigue, we talked about that as part of the side effects from some of the treatments. Anybody who's had cancer, you can't hear the C word and not be afraid of it coming back. Fair done? It's truth, right? It's scary. And I have a friend out in Italy, Dr. Luigi Grassi, I love saying his name, who wrote a paper some time ago talking about fear. Having cancer is kind of like having PTSD. You're always aware. You're always scared. You never know what's going to happen. And I don't know if you guys know it, but that's stressful. It's stressful on you. It's stressful on the people you love. Some of the other things that happen that we don't like to talk about, it's hard to feel sexy when you're getting chemotherapy. Anybody want to debate that? Okay, good. And we've talked about financial stressors. It's hard to go to work when the doctor says the C word and all of a sudden it's like, hey, go here, get this test, get this treatment. Oh, by the way, we're going to go put you in the hospital. And by the way, please be careful of anybody that's sick or and wash your hands all the time, right? So these are really hard stuff that, you know, people say the C word and you rely primarily on the other members of my team who, bless their little hearts, save people's lives. You know, when it all boils down to it. That's what they do. So these are just some of the psychosocial issues. There's, you know, we talked a little bit, Dr. Jarhini talked a little bit about it, and the increasing rise of women being diagnosed with melanoma. And sorry, ladies, America, the rest of the world, puts a lot of emphasis on how people look. Anybody want to debate that? Right? It's really unfair. But, and if you ever read my notes, I try to put it in so, you know, delicate language, but it's about cosmesis, how you appear to the world, right? And it's a big deal. And once that happens, depression can be a factor that is really important that can worsen the course of the disease. You know, it's hard to keep going and going and going. It hurts. It's hard. So depression can make things worse. And by the way, I really am a doctor, so I put up all these nice references just in case. Psychosocial distress. This is a term that came about 20 years ago. So I am a clinical psychologist, or what I'm called a psychosocial oncologist, and I deal only with patients with cancer. And we identified the term distress because up until like 20 years ago, if you had trouble coping with any type of disease, we called you, oh, they're depressed. Oh, they have anxiety. So it seemed rather unfair that, one, you get saddled with a dose of cancer, and then we saddle you with a psychiatric diagnosis. Kind of unfair, right? Right. So the founder of my field, Dr. Jimmy Holland.
8115. Attention, please. May I have your attention?
Everybody pay attention. They're asking for it. So the founder of my field, Dr. Jimmy Holland, a wonderful woman who wrote this really wonderful book. It's called The Human Side of Cancer. And she helped to identify the fact that, you know, we're treating cancer, we're helping people stay alive longer, but we really aren't addressing the emotional side of what goes in. And so we, at her urging, we started changing the way we looked at cancer and how it affects people. So we defined this term distress as to get it out of the realm of psychiatry. Right? It's just not fair. And we also found that people who engage in avoidant coping strategies, you know, the head in the sand, right? Otherwise known as I'm fine, right? They don't cope as well. They don't do as well. But people who address problems directly, that gather information, right? And are active participants with the medical team and say, but what about this? What are my choices? What are my quality of life issues? Those are the people that tend to do better, right? So those are the people that we kind of like. Everybody here, and I want you to like nod your heads yes, everybody here knows their tumor stage, right? Thank you. The stage of your tumor, please nod your head yes. Thank you, that makes me feel better. So tumor stage, your psychosocial characteristics, are you more less avoidant? Are you approaching things directly? Do you have a history of those things? Do you have social support? The wider the net, the better you do. I always ask patients, do you have a good spiritual connection? Right? Because in my field, people who have a spiritual connection tend to do better. In my office, I don't care what spiritual restaurant you go to get fed, as long as you're eating regularly. Right? It's so important, and it goes. When was the last time a doctor did a physical on you and was checking out your lymph nodes and said, hey, are you spiritually intact? Doesn't happen a lot. So those are important things. But as Dr. Gassman was saying, given the overall high survival rates, you know, because the name of this symposium is not dying from melanoma, it is living with. Right? We need to start thinking about quality of life. We need to start thinking about the long-term needs. What happens after? What happens? And we have to start looking at survivorship. We have to start looking at how are you living beyond treatment? What does it mean, not only for you as patients, but you as family members? Right? This is a big deal. And we're just beginning to look at these things in my field. We have interventions. I know I seem, you know, kind of a goof and kind of a silly guy, but we actually do have real honest-to-goodness interventions. And we're looking at what type of active ingredients that people like me can do. We have a big, wide range of therapeutic approaches that can improve quality of life, how well you cope, how well you deal with treatment, how well you can deal with anxiety, that fear of reoccurrence, and depression. I don't want to go into a whole bunch of them, but you know, people think psychologists, does that mean you have a couch? Well, actually, I do have a couch, but it's for me. It's hard work. I got to take my rest. I'm old. So, we have validated treatments, just like Dr. Tahini, just like Dr. Gassman, just like Dr. Funchain we're talking about. We have real, honest-to-goodness therapies that work and that can help. So we know that when you participate in these things, so the doctor says the C word and everything spins out of control, right? Go here, do this, take that. So any intervention that I can provide that helps develop control is a win, right? And interventions in my field, we try to help control the thoughts, the cognitions, that worrying dervish that keeps people up at night, your behaviors. What can you do, right? Want to hear one of my favorite interventions? Get a dog. Right? You got to go walk the dog. Right? Unconditional love, plus you're getting exercise. Right? So anything I can do to help you change the way you think, change the way you behave, and change the way you feel are wins. So we can reduce the health-related distress. CBT is kind of the mainstay and has been for 20, 30 years in the psychological field, and that's cognitive behavioral therapy. The premise of that is the way we think about things changes our emotions, which changes our behaviors, which reinforces our thoughts, which reinforces our emotions. You see this little squirrel cage, right? So we try to help you identify maddening thoughts. And these kind of thoughts live in the world of, like, when it's never going to get better, it's always going to be this way, and the catastrophizing sort of things. We help identify those thoughts and run some different thoughts through your mind to combat them. So cognitive behavioral therapy has been shown to be really effective with depression and in my field. One of the things that's really come to fore is this thing called mindfulness meditation. This was started, about 20, 25 years ago. You think about meditation, you think about the Maharishi Yogi out on the Himalayas. Nah, it ain't that. Mindfulness meditation was started by a guy, and I didn't make this up, all right? The guy who started this, his name is John Kabat-Zinn. Can't make that up, right? And what he's found is this has been mindfulness-based stress reduction therapy for all types of cancers. Has been shown benefit for anxiety, fatigue, stress, sleeping problems, blood pressure. And it takes about 2 minutes, right? It's not rocket science. I can teach it to somebody in just like nothing flat, and they feel like $1 million. It's very cool. So that's one of the things that the interventions that has come to the fore. So I remember the name of this title was Outside In, Inside Out, right? So this is the inside things. This is the stuff that you guys can do. Also, get educated. Be a savvy consumer. If we get you educated before surgery, you're going to do better with it, right? I need to do a quick little plug for Dr. Funchain, Sung, Carolyn, who's been unmentioned up in here. We developed something called a shared medical appointment. We found that when we designed this for early stage, low risk melanoma, so that we get a few people together and we have them share this experience. We have them be their own educators. I mean, Sung does a great job talking about, the ABCEs, DEs, talking about staging, talking about teaching patients how to go over their pathology report. But what it really does is it's the shared medical appointment. It decreases the stigma. It allows them to ask questions of each other. And it's been we had one of these groups, and it was the most wonderful thing. A woman brought in a bag of cosmetics that all had a minimum of SPS 30. It was brilliant. And she shared it with all the guys. Right? You know, melanomas, melanomas. So patients who attend follow-up do better. There's a shocker. You know, you don't come to treatment one time, do you? No. The melanoma, you know, God willing, the creek don't rise, Dr. Gassman takes it out, and it's done. But it still lives up here, yeah? Right? So people who follow up do better. And certain demographic characteristics were associated with higher levels of anxiety. Sorry, ladies. You know, you have more of a societal demand to look better, to take care of people. And these demographics can be identified and supported, and we can target interventions for that. I need to give a shout out to all the social workers in the world. They are fabulous. They are the cornerstone of good psychosocial care, right? They are the outsides. They are the people that help decrease the financial stress, that provide slots of the education, that are the linkage of the services. I'm just a psychologist. I deal with people one-on-one. But these people make things happen. It's really a wonderful thing. And one of my mentors is a social worker, and he likes to remind me, he's like, Joel, I taught you that. You know, so the psychotherapy, a good social worker can do good psychotherapy. So, online resources. Yeah, Dr. Google, right? It's scary stuff out there. You want to hear another one of my favorite interventions? This is where you say yes, please. Yes. Put the mouse down, step away from the computer, and no one gets hurt. How do you guys know what's reputable? Right? Yeah. There's no offense, but there's a bunch of stuff out there that is just downright scary. And I could tell you about lots of scary stuff, but I won't. The cancer support community, they're an online resource. You know, I'm hopeful that there are more people in the audience that are than just Cleveland Clinic folks, because you know what? There may be people out there that don't have this resource, and you can tell them about other resources. The American Psycho-Oncology Society, of which I am a very proud member. We are a group of 500 multidisciplinary clinicians that do nothing but work with cancer patients. And AIM. I took an opportunity to browse their website at length, and I can pretty much tell you they're a reputable website. So feel secure. All right? Where to go and what to do. Go to your cancer center. Go to your provider. Be an active participant in your own care. Get what's right for you. We have 90 people registered here, and that means there's 90 separate different needs. Right? Everybody different. We talked a little bit, it's for you. We talked a little bit about precision medicine, right? Everything has to be addressed. In our local area, we have the Gathering Place, and there's a whole big rivalry between East Side and West Side. And take your pick, go to either one, I don't care. They have multiple good resources there for the mind, the body, and the soul. I mean, art therapy is a wonderful thing. You want to be an active person in your own treatment? Get involved in a clinical trial, right? If it wasn't for clinical trials, we would still be giving interferon. It's true. Am I lying? Right? Be an active participant. And AIM has a nice list of those. NCI, NIH are both reputable, right? So be an active participant in your own care. So, you know, when I wanted to do this outside in, inside out, you know, the biggest resource you have is in this room. I love the fact that there's so many couples and people here because, as was pointed out, I can't see the back of my head. I can't see my back. Be a cancer checker. Be a skin checker. It's a wonderful, only if you love them. If you don't, well, no big. But I'm not going to touch that. Yeah. So if you love them, be a checker. Right? It's the right thing to do. So some key takeaways. Melanoma can cause psychosocial distress. It's going to live and express itself differently with each people. It will live in the mind, in the body, in the environment. And there are certain populations that are more vulnerable to distress. Sorry, ladies. Folks that are younger tend to be both resilient and more stressed. There's a variety of different populations. And there are multiple treatments and resources available. Don't not avail yourself. Capiche? Está bien.